Buenas tardes. Agradezco enormemente la oportunidad que da la Sociedad Mexicana de Oncología para coordinar este módulo de melanoma junto con el doctor Miguel Ángel Álvarez Avitia del Instituto Nacional de Cancerología. El siguiente módulo va a corresponder a melanoma. Sabemos perfectamente bien que hay y ha habido bastantes avances en relación al tratamiento del melanoma y para eso vamos a contar con tres excelentes ponentes. Me voy a permitir presentar al primero de ellos, el doctor Alexander Egermont. Como ustedes saben perfectamente bien, el doctor Alexander Egermont, un brillante cirujano que ha participado mucho en el desarrollo del conocimiento en melanoma. Él, como saben ustedes, es autor principal del estudio Keynote 054 en relación a inmunoterapia con pembrolizumab en melanoma. Él actualmente está en el Hospital de Oncología de Pediatría del Maximus Princess y él nos va a hablar en relación al tratamiento adyuvante y neoadyuvante del melanoma. Doctor Alexander Egermont, muchas gracias por aceptar la participación.
Good afternoon, everybody, dear friends, colleagues, and especially my dear friend, Hector Martinez Said, the president of your society. I will deal with melanoma adjuvant and neoadjuvant therapy developments. I'm Alexander Egermont, and I'm the current scientific chief officer of the Princess Maxima Center in Netherlands, and I'm also active in Germany. So it's with a lot of regret that I'm not with you in Mexico and see you again, but we hope for better times, not before too long. These are my disclosure informations, and let's get started. So in melanoma, there's been two revolutions, one regarding BRAF/MEK inhibitors in BRAF mutant melanoma, and there's been the other revolution, the big driver, the immunotherapy, the IO revolution. Regarding BRAF mutant melanomas, about 50% of the melanoma population, the end result was that a combination of a BRAF and a MEK inhibitor, in this case dabrafenib and trametinib, seemed to be the most effective therapy. It was the first most effective therapy. And these are the 3 and 5 year results. And at 3 years, it's 44% overall survival. At 5 years, it's 34% overall survival. Put these numbers in your head because they're going to be important later. In the immunotherapy development, there's been two key actors. One is anti-CTLA-4, an antibody that avoids the shutdown of T-cell priming in lymph nodes by the interaction of dendritic cells and T cells. And it's with this antibody that you can get continued programming and priming of T cells, and therefore a bigger diversity of T cell clones. The other molecule is anti-PD-1 or anti-PD-L1 that avoids the shutdown of the killing effector mechanism of T cells once they have arrived in the tumor to kill tumor cells, but where they are neutralized usually by PD-L1 expression on tumor cells or on macrophages and other cells. And so these two antibodies have changed the world, and actually not only in melanoma. So in melanoma, the first finding was anti-CTLA-4 with a modest response rate of 20%, but leading to an overall survival, long-term survival rate of 20%, indicating that you could cure melanoma patients with anti-CTLA-4. Anti-PD-1 had a higher response rate, somewhere between 40 and 50%, with an overall survival rate at 5 years of somewhere between 40 and 45%. And all that with much less side effects. So that became the lead molecule. You can combine these two agents, and you look at the top curve. You see the green curve is a combination of ipilimumab and nivolumab, anti-CTLA-4 and anti-PD-1. It leads to a 5-year overall survival of 52% of all melanoma patients regardless of BRAF status. 44% for anti-PD-1 monotherapy. But look in the left panel at the 5-year survival rate in BRAF mutant patients with this combination of Ipi-Nivo. There's a 60% 5-year survival rate, and for nivolumab monotherapy, 46%. And so this is the proper comparator to what I started with, and that was 34% 5-year survival with a BRAF-MEK combination. And so immunotherapy, immunocombo therapy, is almost twice as effective as the BRAF-MEK inhibitor combination. And so there's nothing that even comes close currently to this combination of anti-CTLA-4 and anti-PD-1. Then you can, for BRAF mutant melanoma patients, you can combine BRAF-MEK inhibition plus anti-PD-1. So there's been 2 trials. In green, you see the INSPIRE trial, which was positive, vemurafenib and cobimetinib, plus atezolizumab, an anti-PD-L1, and the COMBI-I trial, which was a negative trial, dabrafenib plus trametinib, plus or minus spartalizumab, which is the anti-PD-1 molecule. The difference, however, in median progression-free survival between these 2 trials was it was 4.5 months between the comparator arms in INSPIRE, and it was 4.2 months in the COMBI-I trial. That difference is only 10 days, and that made the difference between a positive and a negative trial. Overall, you can say it's clearly not superior to anti-PD-1 monotherapy, because just look at the curves of anti-PD-1 monotherapy, and it's clearly inferior to the anti-PD-1 plus anti-CTLA-4 combo immunotherapy. And so if you do these trials, they should have had an anti-PD-1 monotherapy control arm, and they should have had an anti-PD-1 plus anti-CTLA-4 positive control arm, and only then would you make really useful conclusions. So I started like this because the findings in advanced disease have translated now in the adjuvant setting. And so after a long period of marginal effects with interferon in stage 2 and stage 3 melanomas, we are now in the new era. And in the new era, those new treatments, ipilimumab, nivolumab, dabrafenib plus trametinib, and pembrolizumab, were all tested in the adjuvant setting, and they all were superior to placebo, or in case of nivolumab, to ipilimumab, and they were all approved by the FDA in the years 2015, 17, 18, and 19. And here are all the publications regarding this. And so you can say that based on relapse-free survival, ipilimumab top left was approved, COMBI-AD top right was approved, nivolumab was superior to ipilimumab, which had become the new approved therapy in the United States. And Nivo was approved, and then pembrolizumab, as you can see here, against placebo, also was approved in lymph node positive melanoma. The only data that are available for long-term good overall survival impact data are for the first trial, adjuvant therapy with ipilimumab. You see that it translated exactly from relapse-free survival into distant metastasis-free survival into overall survival with basically identical hazard ratios. And this is therefore very comforting for what we may expect for the anti-PD-1s. Ipilimumab is no longer used because it was too toxic. There were too many side effects. So for the BRAF-MEK combination, it's a treatment only for patients with a BRAF mutant melanoma. That's only 50%, 45 to 50% of your patient population. And you can randomize the dabrafenib plus trametinib versus the placebos. And then here are the 5-year results. And at 5 years, you see a 16% difference in relapse-free survival, 52 over 36% for placebo. When you look at distant metastasis-free survival, it's 65% over 54%. All these observations are highly significant. The overall survival was not had not yet met the overall survival number of events. Then at SMeO, whereas the Combi-AD trial was reported at ASCO, the SMeO now, just a month ago, there were two updates, one on the CheckMate 238 trial, adjuvant nivolumab versus ipilimumab, 4-year results, and pembrolizumab versus placebo, the ORTC Keynote 54 trial, and that presented the final analysis of distant metastasis-free survival at 3.5 years median follow-up. So the CheckMate 238 compared nivolumab for 1 year to ipilimumab high dose for 1 year. And here are the results at 4 years for relapse-free survival. You see 52/41%, significant difference. For distant metastasis-free survival, it's 59/53%. So it has been reduced to a 6% difference. It's just borderline significant, 0.045 with a 0.79 hazard ratio. And then due to all and various crossover mechanisms after distant metastasis have been announced, the availability of Ipi-Nivo as a combination, the availability of a BRAF-MEK combination for BRAF mutant patients, you see at this point in time, at 4 years, not an overall survival benefit because of those later treatments. This was just an exploratory analysis. The Keynote 54 EORTC 1325 trial was the trial where we compared 1 year of pembrolizumab, flat dose every 3 weeks for 1 year, versus placebo in lymph node positive patients. And at recurrence, patients are unblinded. And if they were placebo patients, they are offered the trial medication pembrolizumab for free for up to 2 years. And so this is the only adjuvant trial with a crossover design to answer in the end the question, should we give pembrolizumab to all patients immediately after surgery, or just do we start at time of relapse to those patients who actually relapse? And that result will eventually emerge. So the updated relapse-free survival analysis showed 20% differences at 2 and 3 years, and that's of course highly significant. The distant metastasis-free survival analysis shows differences of 13, 14, 16% in that range for 2, 3, and 3.5 years. This is of course bigger than in the nivolumab ipilimumab arm because here we are randomizing patients against placebo. It is important to realize that you basically see the same impact across subgroup stages. You know that stage 3A has a much lower risk for relapse than stage 3B or stage 3C. But the impact of adjuvant pembrolizumab in each group in terms of hazard ratio is basically the same, is around 0.59. Interestingly, the efficacy in terms of hazard ratio was 0.53 for BRAF mutated patients, was about half of the patient population, versus BRAF wild type patients where the hazard ratio was 0.73. And so what does it mean? It means that for BRAF mutated patients, anti-PD-1 is a true alternative to BRAF-MEK combo because it's exactly the same or very similar hazard ratio. It was 0.55 in the Combi-ID trial with dabrafenib and trametinib. And so that's what's here in the conclusions. I already mentioned that. At the bottom, I say overall survival benefit with adjuvant pembrolizumab. This trial is actually the only trial that has a design to give that answer. In the end, but events are coming in very slowly, and we don't think we will have this answer within 4 or 5 years. Adjuvant nivolumab plus ipilimumab, the combo in stage 3BC and resected stage 4 was a big trial where there was an interim analysis in November 2019 where at that point in time the primary endpoint was not met. It was a combination of Nivo plus Ipi versus Nivo. But this trial clearly needs more maturation for a definitive readout. Interestingly, there is a trial in the high relapsing group of patients resected stage 4 that was reported in the Lancet this year, that came out of Germany, Dr. Zimmer, and was initiated by Dirk Schadendorf. And it shows that Ipi-Nivo is superior to the middle curve, Nivo adjuvant therapy, superior to ipilimumab, the bottom, to placebo, sorry, the bottom curve. So it indicates that Ipi-Nivo is always the worst the situation, always the best treatment option, apparently. The other movement is, can we go into stage 2 with our anti-PD-1s and with our other tools? But does stage 2 present a sufficient elevated risk for relapse to justify adjuvant therapy? And basically, we can already say that up front, we should be able to better identify those patients who will relapse in stage 2 domain, because the stage 1 domain here is the top 1A and 1B, and then you have here curve orange is 2A, then blue 2B, and then brown is 2C. Now clearly 2B and 2C are similar to stage 3 melanoma. 2A is similar to the best of stage 3A, but the 10-year overall survival rate, melanoma specific overall survival rate, is 88%. So that's not a huge loss of life to work with, so to speak, to detect a therapeutic impact. When we look at relapse, when we look at melanoma specific survival and we compare stage 2A and 3A very close to each other at 88%, then 2B, 2C, and 3B are within the range of 75 to 82%, and 3C is, of course, clearly worse with 60%. So this is the encouraging thing, and that in the pembrolizumab trial, it's very obvious that the hazard ratios are very good in the low risk 3A, that all hazard ratios are basically the same with overlapping confidence intervals. So we expect the hazard ratio of stage 3 melanoma, 0.58, 0.59 for relapse-free survival, to translate also into that type of hazard ratio in stage 2 BC. So what happened in stage 2 BC? Well, we actually reported this year, just a month ago, the trial of pegylated interferon in ulcerated primary stage 2B, and we demonstrated that there was a significant impact on relapse-free survival and a hazard ratio of even 0.39 for distant metastasis-free survival in ulcerated melanoma. And this trial was based on the observation of a meta-analysis of all melanoma adjuvant trials that showed that in non-ulcerated primary melanomas, adjuvant interferon therapy had no effect whatsoever, that all the effect was obtained in ulcerated primary melanomas. And this was therefore a confirmatory trial of that observation. But now the new drugs. So anti-PD-1 antibodies are being investigated in the Keynote 716 trial. Pembrolizumab for 1 year flat dose every 3 weeks versus placebo in stage 2BC patients. Checkmate 76K compares nivolumab at 480 milligrams flat dose every 4 weeks for 1 year to placebo. The randomization here is 1-to-1. Randomization here is 2-to-1. This trial, the Keynote 716 trial, will complete accrual by the end of this year, and Checkmate 76K, I guess somewhere next year, but distinctly later. Then there is an adjuvant therapy trial that includes high-risk stage 2 melanoma across the board from 2A to 2B to 2C in Germany, initiated by Professor Schandorf. And here patients are being stratified for high-risk score or a low-risk score on a gene expression profile of the primary, and in the high express score, you randomize 2 times more patients than in the low risk group. And so this is a trial that tries to identify the patients who have a higher risk for relapse and work with that, and then include those 2 stage 2A patients. The EORTC 1902 trial is also including stage 2A, BC, and is adjuvant encorafenib binimetinib, so BRAF-MEK combo for 6 months versus placebo. And we use the Skyline DX algorithm for stage 2A patients in this trial. That should be about 30% of patients in this trial. The CPGEP algorithm will identify those on the primary who have the highest chance of relapsing, because this is now a mandatory thing in our overall development system of doing better in melanoma, is that we should realize that 50% of all melanoma deaths actually started as a stage 1-2A patient. And we should be able to identify on the basis of analysis of the primary who will actually relapse. And that is, of course, a very active field of research. And this was published in the Journal of Clinical Oncology, Precision Oncology, the model combining the 8-gene genome profile on the primary combined with Breslow and age as clinical pathologic factors. And that leads to an algorithm that predicts actually sentinel node positive and negativity very accurately. The negative predictive value is 98%, meaning that you can actually often indicate that patients can safely forgo sentinel node staging. And it identifies patients who actually have a sentinel node negative node who will then still relapse. And this is exactly what we need, because this classifier tells you who in the sentinel node negative stage 2A patients are the 2 out of 3 patients who actually will relapse. In the 1B cohort, actually 3 out of 4 patients who will actually relapse in spite of being sentinel node negative. And that has been just published in the European Journal of Cancer, where we have demonstrated this. The blue line are patients who are both sentinel node negative and classifier CPGEP negative. The red line is patients who are sentinel node positive and CPGEP positive. But of course, the line of interest is the dark blue line. These are patients who are sentinel node negative, but they still relapse, and they relapse at the rate of 28% at 5 years. So these are actually candidates for adjuvant therapy. And so this classifier is identifying successfully most of those patients. And this translates, of course, in similar curves for distant metastasis-free survival and overall survival. So that's where we're going with the adjuvant therapy landscape. The next revolution is neoadjuvant immunotherapy, and it's all about the combination of anti-PD-1 and anti-CTLA-4. Neoadjuvantly given prior to scheduling lymph nodal surgery for palpable nodes. Now, if you give nivolumab monotherapy in a pilot study, there was a 25% overall response rate. These were PCRs, so pathologic complete responses. If you give the combination of IPI and nivo, you get a 75% overall response rate with over 50% complete responses. So at the National Cancer Institute in Amsterdam in the Netherlands, they took this further into a study where they compared patients who first had surgery for that's a therapeutic lymph node dissection and then followed by adjuvant anti-PD-1 therapy, or patients who were treated with 2 courses of ipilimumab plus nivolumab and then underwent their surgery, and then they got another course of ipi-nivo. And they did a biomarker study in the sense of T-cell clones and TCR. And they demonstrated that the ones who got adjuvant nivolumab after first having undergone surgery had a pattern which was much superior in the patients who got ipi-nivo prior to surgery and ipi-nivo right after surgery. And it showed that ipi-nivo induced many more and much higher level of T-cell clones to wipe out the tumor. And so they took that into a trial. They first determined that IPI, low dose, 1 milligram per kg, NIVO, 3 milligrams per kg, give excellent results, less toxicity, but still a 77% pathologic response rate. And so they took that, sorry, I need to, I cannot show this. So they show that actually the ones who had a pathologic complete response, 60 out of 64 patients, there was only one patient who relapsed in 2 years. And it so shows that you could actually cure these patients with 2 courses of ipi-nivo prior to surgery. So they designed then this trial, the PRADO trial. And the PRADO trial is a trial where you work with the combination of ipilimumab and nivolumab prior to surgery. And this is the schedule. So these are patients who are stage B, C, stage 3. And so they have a palpable node or multiple palpable nodes, and they get ipi-nivo 2 cycles prior to the surgery. They then have scannings, and then there is the largest node, which was the index node, is the only node that is excised. And if that node has a pathologic complete or near complete response, so that's bigger than 90% necrosis, there is no more therapeutic lymph node dissections, and there is no more adjuvant therapy, just follow-up. If there is a partial response, that means bigger than 50% necrosis in your lymph node, between 50 and 90, then they still do a therapeutic lymph node dissection. And if you did not respond, then you go into therapeutic lymph node dissection followed by adjuvant nivo or BRAF/MEK combo therapy. So what is the current status of this trial? And so there was a report at ASCO this year by Christian Blanc over the first 100 patients, and it shows that pathological response rate was confirmed, 71%. Grade 3/4 side effects, 22%. Therapeutic lymph node dissection omitted in 60% of patients because of pathologic complete or near complete responses. And so this intervention is going to do away with the majority of therapeutic lymph node dissections. That is what's going to happen. And not only in melanoma. In melanoma, we say no more therapeutic lymph node dissection, more than 50% of patients with palpable nodes. Bladder cancer, well, this is predictions. This has not yet been proven, but this is predictions. In bladder cancer, it's been demonstrated you can get 50% complete responses for T3 bladder cancers and avoid, therefore, cystectomies. In MSI colorectal cancer, there was a publication from the NCI Amsterdam, and 19 out of 20 rectal cancers had a pathologic complete response by induction therapy with ipi-nivo. And so these were still operated. Where is this going to go? This means that in the future, there will be biopsies. And if there's pathologic complete response, there will be no more resection, and there will be observation with endoscopy and MRI. And so now there's a whole avalanche of neoadjuvant trials, also with ipi-nivo in lung, head and neck, esophageal, gastric, breast, and even in glioblastoma multiforme. That is where the landscape is going. I thank you for your attention.
Agradecemos enormemente la participación del doctor Alexander Egermont y excelente presentación. Y bueno, les recuerdo que las preguntas serán al final del módulo. Vamos a tener una mesa redonda. Y bueno, continuando con el programa, tengo el agrado, el gusto de presentar a un gran amigo de México, al igual que todos nuestros ponentes, el doctor Charles Balch, quien es, además de un agente que lleva mucha experiencia en el melanoma y ha escrito muchísimo de melanoma. Bueno, también lo conocemos por múltiples conferencias que ha dado en México, todas ellas brillantes. Y bueno, a continuación, el doctor Charles Balch va a hablar del manejo quirúrgico en pacientes con melanoma con ganglios linfáticos metastásicos. Doctor Charles, muchas gracias.
Buenos dias, everyone. I'm so pleased to be part of this SMeO virtual Congress, and I want to congratulate my dear friend Hector Martinez Said for his leadership as president of the Mexican Oncology Society. It's a pleasure for me to follow up on this exciting scientific work that has been presented by my friend Dr. Egermont in Europe. And this is the future that all of us in the world, including those of you listening in Mexico, will be experiencing. And as I've told in many of these webinars to a surgical audience, each surgeon must be prepared to understand oncology management and the role and the timing of surgery in oncology management, because in the future, surgery will not be the first treatment for many forms of cancer, and that there still is an important role in the surgical management of lymph nodes, but we need to understand to be part of a multidisciplinary team. Even with the advances that Dr. Egermont had shown you with neoadjuvant therapy, it is still going to be important for staging whether or not the patient has a pathological complete response or whether or not there is resistant cells for which the therapy may be changed as a result of the molecular profile of the resistant cells in patients who do not experience a pathological complete response as they designed in the Prado study. And those of you who treat breast cancer know that after neoadjuvant and HER2 positive patients, those who did not get a pathological complete response benefit by switching to TDM1 as adjuvant therapy afterwards. So staging will continue to be an important part of our therapy, both as surgery in the first treatment, such as the sentinel node procedure, but also importantly in patients who have undergone neoadjuvant therapy. We also know that removal of metastatic lymph nodes prevents symptomatic growth before a patient dies of distant metastasis. And of course, as we get more precise of understanding where the metastases are, we want to move away from removing normal lymph nodes without metastasis and the lymphatics around them, which can result in chronic lymphedema. Now, I put it here on increasing survival rates, but this is actually maybe present only in patients with very early disease. But any one of these goals can be justified when the benefits of the surgical procedure outweigh the risk in individual patients. Now, as you know, there's a whole spectrum of lymph node metastasis in melanoma, which we call stage 3. And that ranges from microscopic, shown on the right side, which may only have 10 to 500,000 cells, to this patient on the left side who had 20 metastatic lymph nodes, literally billions of cells in the lymph nodes. And even though surgery is not going to improve survival rate in this patient, it can prevent symptomatic disease in this patient by surgically remove them before they develop and die of metastatic disease later on. So there is a role in selected patients for regional disease control. Now I want to pick up where Dr. Egermont said and support totally in patients who present with palpable, clinically detectable lymph node metastasis that increasingly in many, if not most of our patients, we're moving towards neoadjuvant therapy, either with the checkpoint inhibitors as monotherapy or combination, or in BRAF mutant patients with the BRAF MEK inhibitors. I totally agree with Dr. Egermont that the results now show that our treatment of choice is the combination of checkpoint inhibitors. But the potential advantages of having surgery in this neoadjuvant approach is we can determine the patient's response to the existing therapy, and in those patients who do not have a complete response, to change our treatment afterwards. Here's just an example that's from my colleague, Dr. Merrick Ross, of a patient who had neoadjuvant anti-PD-1 for advanced melanoma. As you can see, this patient before treatment had bulky disease in the groin and in the pelvis. And after 4 courses of neoadjuvant therapy, you could see that the tumor was reduced, but there was still residual disease based upon CT scans, both in the groin and in the pelvis. However, at surgery, there was a pathological complete response, and all of the masses seen on CT scan were in fact scarring and inflammatory disease. There was no viable tumor left. And this just illustrates the importance of determining pathologically what we can't do as well radiologically in patients who do not have a complete absence of tumor by radiological assays. Now, in patients who present with subclinical disease, normal lymph nodes in the region of a primary melanoma, that a sentinel lymph node staging, I believe, is standard of care for all of these patients, except those who may be very elderly or have life-limiting comorbidity. This is an easy and reproducible procedure. It gives us valuable information for staging, and it is recommended for patients who have clinically negative disease. As shown here, that more than 80% of stage 3 patients in the United States now present with subclinical disease, and their stage 3 disease is actually detected by sentinel node pathology. Now, I want to introduce here a little paradox in our management recommendations for stage 3 melanoma. If I have a 10 millimeter or 1 centimeter tumor in a thin patient in the axilla or in the neck, I might clinically detect that, put a needle in it, and determine that this is clinical stage 3 disease, and then the recommended treatment would be a complete lymphadenectomy. However, if you have the same 10 millimeter tumor in a more obese patient deeper in the axilla, you might not palpate that. You do a sentinel node, you find they have metastasis, and then, according to some recommendations, we would leave the remainder of the lymph nodes alone. And I would submit that in that patient, that there may be a rationale for doing a more complete lymph node dissection because of the increased risk of non-sentinel metastasis in a patient like that may be as high as 40%. So we need to be sure that as we're listening to recommendations from clinical trials and guidelines, how to apply those in our individual patients. So here's the implications for the sentinel node positive patients, which nowadays are the majority of our patients that we see in our practice. First, that the sentinel node biopsy is not only an important staging tool, but I believe, based upon the MSLT trial number 1, it's likely to be therapeutic in the majority of these patients by removing the only metastasis that had escaped and was growing in the sentinel node. In patients who are justified of having a complete lymph node dissection, that it does provide excellent regional disease control with a very low regional recurrence rate. However, there is morbidity associated with that, especially in patients having inguinal lymph node dissection. The clinical node, the MSLT 1 and 2 trials and the trials done in Europe are practice changing. And I think we can conclude this is no longer recommended for routine use in patients who have spread to the metastatic, to the sentinel node. And I'll go over some caveats about how we should approach this, which to me should be a selective use of doing a completion lymph node dissection in a patient where understanding for staging, non-sentinel node involvement could help in the decision to offer adjuvant therapy when the risk of regional disease is greater than the risk of the distant disease at that point in time in the patient's natural history. and in identifying the highest risk group who should start adjuvant therapy as soon as possible. Now, I want to remind everyone about the natural history of melanoma based upon surgically treated patients who have not had adjuvant systemic therapy as published in the 8th edition of the AJCC manual. And I wanted to point out here that one, the number of lymph nodes is a prognostic factor and is used in staging. So where that is important, that knowing the number of lymph nodes is important, but that can be taken into account as one rationale. I'd also point out in patients who have 3A disease that their 10-year survival rate is 88%. That means at the time of diagnosis, they only have a 12% risk of having distant disease. Now, I point out that this number in surgically treated patients not having adjuvant therapy is higher than the results Dr. Egermont showed in the clinical trials. And I think one explanation for that is that we as surgical investigators may not put patients who have favorable prognosis, thinner tumors, low mitotic rate, and so forth, or lower tumor volume, we may not put those patients in our clinical trials. So we have to remember there may be some selection bias of patients who we select to go into clinical trials as one explanation why the 5 and 10-year results may be somewhat lower than in these kind of studies reflecting the natural history of surgically treated disease. I'd also point out that the number of lymph nodes is an important prognostic factor in determining risk for distant metastasis. And here again, in the green line, patients who have one positive lymph node in the AJCC, and this is going to be mainly micrometastasis based upon the sentinel node, 10-year survival rate is 96%. So we have to take this into account as we're selecting patients for expensive adjuvant therapy, which exposes patients to not only cost but toxicity when the benefit may be small. Now, Don Morton, who was the pioneer and the inventor of the sentinel node, did 2 very well-designed prospective trials, the largest trials conducted at the time, MSLT-1 and 2. And just to summarize, what he found in the MSLT-1 trial is that in the majority of patients, 67% of patients, the metastases were confined only to the sentinel lymph node. And what we know from the MSLT-2 trial, the sequel, is that only 33% of patients who had a sentinel node metastasis went on to have metastasis in other areas. So the question is, can we identify those patients who are at increased risk for non-sentinel metastasis and for staging and for regional disease control, perform a more complete lymphadenectomy, assuming that the benefits outweigh the risk? Now, Dr. Morton's first trial, MSLT-1, remember that there were 2 randomization to patients and only a minority of patients had a positive node. And I wanted to just point out in the patients who had a positive sentinel lymph node, there was an increased survival rate compared to those patients who had observation and later had a therapeutic lymphadenectomy. So this may indicate that there is a small subset of patients with very early disease and small sentinel lymph node metastasis who may have a survival benefit simply by removing the sentinel node and no further surgical therapy and no further adjuvant therapy. And as you can see in the multifactorial analysis, that the sentinel lymph node status was the most significant prognostic indicator, the predictor of both disease recurrence and death. So it is important for staging. And therefore, I think there's compelling evidence favoring the staging value of the sentinel lymph node, even if we don't do any further intervention in the lymph nodes. Now, Is it necessary to remove non-sentinel lymph nodes with a completion lymphadenectomy, assuming that there may be subclinical second-tier metastasis after a sentinel node biopsy? Which, remember, we generally don't know until the patient has completed their surgery. We find out this later on with the pathology report, and we would have to go back and do a second operation. Now, Jeff Gershenwald in 2008 published, I think, a very important paper that is sometimes overlooked, and that is looking at the largest focus of sentinel node metastasis. And the key point of this paper was in patients who had a tumor burden more than 2 millimeters, up to 10 millimeters, there was a 25% risk of a positive non-sentinel lymph node. And if the metastasis was more than 10 millimeters, that risk was 45%. So I believe in our practice, we need to take this into account when making a decision in individual patients, whether for staging purposes and regional disease control, whether to perform a completion lymphadenectomy. And I wanted to just show two important studies demonstrating that patients who had a low tumor burden in the sentinel lymph nodes had a completely different disease-free survival rate, especially those who had tumor burden less than 1 to 2 millimeters compared to those who had a larger tumor burden. And in the AJCC staging data, if one looks at the tumor burden in large numbers of patients who, remember, did not have any adjuvant systemic therapy, that those patients who had a tumor burden up to 2 millimeters had an 89% to 96% 10-year survival rate. And those patients whose survival dropped down were in those who had a larger tumor burden in their sentinel lymph node. And those may be both candidates for adjuvant therapy if they haven't had neoadjuvant therapy, and those who may be candidates for completion lymph node dissection. Now, as all of you know, that Dr. Morton and then Mark Ferries and others went on and did the MSLT2 trial, starting with patients who had a positive sentinel node and randomized them in 2,000 patients to those who had a standard, at the time, completion lymph node dissection or observation. And it's important to point out that these patients had serial nodal basal ultrasound to detect metastasis earlier than we might with clinical detection. And if they had a nodal recurrence, then they had a completion lymphadenectomy. And as you know, these were the results published in the New England Journal of Medicine, which did demonstrate three conclusions. One is the immediate completion lymph node dissection increased the rate of regional disease control. Two, it provided prognostic information. But three, it did not increase melanoma-specific survival. So that cannot be the rationale for doing a completion node dissection. And if we're going to do it for the first two reasons, we should do it in patients we've selected because the prognostic information is important and the morbidity is acceptable in individual patients. And I would have submitted both the MSLT2 trial and in the German trial, there was a great deal of selection bias in that the median tumor burden in the MSLT2 trial was less than 1 millimeter, and only 1/3 of the patients had a tumor burden greater than 1 millimeter. So those with larger tumor burdens in the sentinel node were really not part of the trial. And similarly, in the DCOG trial in Germany that was published in Lancet, also not showing a melanoma-specific survival rate, that the vast majority, 86% of patients, had a tumor burden of 2 millimeters or less. So very clearly, if you have a patient with low tumor burden, there is no benefit whatsoever to doing a completion lymph node dissection because the risk of non-sentinel metastasis is so small. So how to interpret these two trials? One is there is no survival benefit of lymphadenectomy in any patient who has a metastatic lymph node, and that may be true, but paradoxically, we do routinely perform completion lymphadenectomy for patients with clinically detectable nodal metastasis, even though we don't improve their survival rate, but for regional disease control. So I would take a middle of the road approach to say, one, a completion lymph node dissection is necessary to remove metastasis in regional lymph nodes, but I would reject that option. But based upon the MSLT2 trial, I would suggest that in patients with low tumor burden, there is not a benefit of sentinel node, and based upon prognostic factors in clinical trials, to proceed with adjuvant systemic therapy. But I do believe there is some patients individually where a completion lymph node dissection might be performed selectively when there's sufficient risk of non-sentinel metastasis based upon increased tumor thickness, increased mitotic rate, presence of ulceration, and increased tumor burden, especially more than 2 to 5 millimeters in the sentinel node. And also when the staging information has value for determining further therapy or counseling the patients about prognosis. And I'd say especially in patients where you're not reliable in their follow-up or you're not able to follow them with ultrasound as was performed in the MSLT2 trial. So getting back to Dr. Gershenwald's trial, this is from Dr. Merrick Ross's working model of predicting risk for additional positive nodes. They came up with a scoring system, which is, you can see here, which is based upon breast low thickness, the sentinel node focus of metastasis, and the number of sentinel nodes harvest, and identified, again, a group of patients who had a higher score where they had a higher rate of non-sentinel metastasis. That does not mean that we should necessarily do a completion lymph node dissection, but it's information we need to take into account in making this decision in individual patients. So when not to perform a completion node dissection, when the benefits for staging and regional disease control do not outweigh the risk and complications and morbidity in individual patients. I think that would especially apply in doing a groin dissection, especially in older patients and those patients who are obese because of lymphedema and wound complications that will occur. But conversely, the morbidity of an axillary dissection and neck dissection is not the same as it is with a groin dissection. We should not do that in patients who have any life-limiting comorbidity, such as heart disease, lung disease, or kidney disease, those that significantly increase risk for extremity lymphedema, and especially based upon the clinical trials when the tumor burden in the sentinel node is small and the probability of non-sentinel node metastasis is low. So the NCCN guidelines and the ASCO guidelines, I think, would summarize what I just said in patients who are sentinel node positive, that we need to sit down with the individual patients, discuss the indications, benefits, and risks, look at their pathology, as I discussed previously, and decide whether to offer nodal observation with ultrasound follow-up or whether to perform a completion lymphadenectomy. Now at MD Anderson, we are often now going ahead with starting adjuvant systemic therapy immediately and waiting for 2 to 3 months, reevaluating the patient at that time, and then going back and doing the completion lymphadenectomy so that we are starting their systemic therapy as soon as possible and not delaying it with yet another operation. So I want to thank you for this opportunity and look forward to the discussions afterwards.
Tu excelente presentación. Vamos a continuar con el programa. Creo que ha sido muy enriquecedor ver dos grandes ponentes y vamos a concluir también con un gran ponente y un gran amigo de todos nosotros, el doctor Sanjeev Agarwala, que ya lo conocen ustedes, oncólogo médico y con mucha experiencia en el área de inmunoterapia, con múltiples papers y obviamente con toda la experiencia del mundo para poder discutir acerca del tratamiento sistémico de la enfermedad avanzada. Doctor Sanjeev Agarwala, muchísimas gracias por estar con nosotros el día de hoy. Le mandamos un abrazo hasta allá.
Good afternoon. It's a pleasure for me to give you this talk on systemic treatment of advanced melanoma, immunotherapy versus targeted therapy. I'm very sorry that I cannot be in Mexico to give this talk live, but we have some restrictions at my hospital for quarantine. And hopefully next year at SMeO, I will be able to come again to Mexico and participate. Thank you to Dr. Hector Martinez Said and the organizers for allowing me to participate. I'm going to cover the topic of immunotherapy versus targeted therapy for melanoma, and I will talk about both metastatic disease and adjuvant therapy. I will start with immunotherapy for melanoma, and we will start with metastatic disease. I think everyone is very aware that the drug which changed the entire field of not only melanoma, but I think oncology for immunotherapy was ipilimumab. And this trial that was done many years ago now that established the role of ipi or ipilimumab in the metastatic treatment, the treatment of metastatic melanoma when it was compared to vaccine and to DTIC. So this led to the FDA approving this therapy for melanoma in all lines of treatment, and was the first drug which really created a positive clinical trial for melanoma in the metastatic setting. The most important data with this drug is shown here, that now we have follow-up that is longer than 10 years, in fact, approaching now 15 years. And you can see that the curve is completely flat now, which means that there is a prolonged durable benefit of this treatment in a patient population about 20%, as you can see from this graph. So 20% of patients with ipilimumab treatment as a monotherapy have a long-term benefit for the treatment, patients with metastatic melanoma. Now we know that with immunotherapy, anti-PD-1 agents have been superior and have really revolutionized the treatment of not only melanoma, but multiple cancers. And in melanoma, in fact, the first trial that showed that anti-PD-1 is better than anti-CTLA-4 is this trial, KEYNOTE-6. And this was a trial comparing pembrolizumab to ipilimumab in the frontline setting for metastatic melanoma patients. This was done a few years ago, and I think you're very aware of the results of this trial. But pembrolizumab, anti-PD-1, was superior to ipilimumab, anti-CTLA-4, and we now have follow-up that is beyond 5 years, which shows that the curves are once again flat. And essentially, the way I like to think about it is that the anti-PD-1, in this case pembrolizumab, is 2 times more effective than ipilimumab. It's about 40% long-term survival compared to 20% long-term survival with ipi. And this applies, by the way, to both pembrolizumab and nivolumab. There really is no difference between these 2 drugs in efficacy or even toxicity. They are both anti-PD-1s and they both work very well. What about combining anti-PD-1 and anti-CTLA-4? This very important trial, CheckMate 67, was done to see if combining ipi and nivo, so ipilimumab and nivolumab, anti-CTLA-4 plus anti-PD-1, is better than anti-CTLA-4, and also could it be better than anti-PD-1 alone? I want to remind everyone that this trial was really powered to only show the difference between the combination versus ipi, and not for the combination versus nivo alone. It was not powered for that, but we do have data from this trial, which shows that now with long-term follow-up of more than 5 years, there is an improved overall survival with the combination ipi-nivo versus nivo and versus ipi. You can see the 52% for the combination at 5 years versus 44% for nivo alone versus 26% for ipi. So ipi, of course, is way down, but there is a difference between combination and nivolumab alone, showing that there is a superiority, but it was not statistically significant. And that is important to realize because the study was not powered for that. However, this difference that is there, about 6%, is important clinically. So the question really comes in the clinic is the choice between combination therapy or monotherapy. If you choose immunotherapy, you have the option of giving anti-PD-1 alone, or you can give anti-PD-1 plus anti-CTLA-4 together. So how do we make this decision? In the clinic, we think about this for our patients, and the decision is based on 2 factors mainly, efficacy and toxicity. So let's start with efficacy, and I want to show you the progression-free survival for CheckMate 67. I did show you the overall survival already. But for progression-free survival, you can see very clearly, and it's a good endpoint, that now at 5 years, the green line, which is a combination, is completely flat. And that is 36% versus nivolumab alone at 29%. And IPI is, of course, only 8%, which is well known. So there is a superiority numerically of IPI-NIVO versus NIVO alone, showing that it is more efficacious, but the difference is modest. What about toxicity? This is important because we know that when you combine IPI and NIVO together, CTLA-4 plus PD-1 together, you get increased toxicity. In fact, the combination is about 58%, almost 60% grade 3 and grade 4 toxicity in this trial of the combination versus NIVO alone, which is only 20%, and IPI is about 30%. So this combination actually increases toxicity more than you would just add toxicity of one plus the other. And not only is the toxicity coming on more frequently, but it comes on earlier and takes longer to resolve. So this looks like a concern that the toxicity is quite high, it comes on soon, and it takes longer to resolve. But there's some very interesting data that has been recently analyzed, which because of the toxicity of the combination, we are finding clinically that most patients do not get the full treatment, okay? They will get maybe 2 or 3 cycles of combination therapy, and then because of toxicity, they stop the treatment. When you stop the treatment, you may give steroids, you follow the patient, and many of these patients do not progress anymore. In fact, they may continue to respond and the benefit can be prolonged. And this is very interesting because there's something called treatment-free interval. And when you see patients who are receiving IPI-NIVO combo together, their time that they spend without treatment is much longer than the people who get monotherapy. So in other words, if you give a toxic treatment, it is more effective and you stop it sooner. So in some ways, that is a good balance and better for the patient perhaps. So that is an important point. However, we don't know the correct answer in a large randomized trial. And I think the choice will remain. Patients will be choosing with their physicians combination therapy or monotherapy. But based upon the data I've showed you, many of the clinicians in the USA are picking combination therapy over monotherapy. What about adjuvant therapy? For adjuvant therapy, we have no combination. It's only anti-PD-1, and it's either nivolumab or pembrolizumab. However, I want to start with IPI to show you what the data with ipilimumab alone is. This is an EORTC trial, 18071, done many years ago now, comparing IPI to a placebo. And this trial in adjuvant therapy, high-risk melanoma, these are patients who have been surgically cured and are receiving adjuvant therapy, did show a benefit in relapse-free survival and overall survival. There was a significant difference of IPI versus placebo. However, the toxicity was extremely high. In fact, there were 5 grade 5 toxicities. In other words, 5 deaths from treatment, which of course is not acceptable. And even though this was approved as monotherapy, we have not really used it that much. And now there are multiple trials now showing that we don't need to use IPI in the adjuvant setting at all. This is the most important adjuvant trial, I think, that was done comparing in high-risk melanoma, nivolumab versus ipilimumab. So this was based upon the previous trial showing that IPI at 10 milligram per kilogram, I should have mentioned that in the adjuvant trial for IPI, it was 10 milligram per kilogram, which is very high dose. We don't really use that dose. But that was the drug that was the dose that was used, that was FDA approved. So nivolumab at standard dose versus IPI was done in an adjuvant clinical trial. And very good news, data that was just updated at SMeO a few weeks ago, confirming that there is improvement in the primary endpoint of relapse-free survival for nivolumab anti-PD-1 over CTLA-4 ipilimumab. So just like in metastatic melanoma, in adjuvant therapy as well, anti-PD-1 is better than anti-CTLA-4, and most importantly, much lower toxicity. So that is very good news for patients. We have another trial which confirmed this as well with pembrolizumab. This is a very important trial, Keynote 54, which looked at giving pembrolizumab, but in this trial, the control arm was a placebo. And this was also updated recently at ESMO 2020, and you can see that there is a sustained benefit and hazard ratio of 0.59 now at 42 months of follow-up or beyond, which showing superiority of anti-PD-1 over placebo. So 2 clinical trials in the adjuvant setting showing that anti-PD-1 is an effective treatment for high-risk melanoma patients. Let's now talk about targeted therapy. So targeted therapy, we'll start with metastatic disease and we'll talk about adjuvant therapy. Targeted therapy is based upon the fact that there is a very important pathway in melanoma called the MAP kinase pathway. And in this pathway, there is a BRAF, you can see there in orange. And this is mutated in about 50% of melanoma patients, at least in the United States and Western Europe. In Mexico, I know it's a little bit less. But this mutation is very important because it drives the cancer cell, the melanoma cell, towards growth and survival. So it's a mutation that is driving the cancer, and finding a drug that may inhibit this mutation would be very useful. And as you all know, the first drug which was effective targeting BRAF was vemurafenib. But since then, there have been multiple clinical trials showing that in this, if you target this pathway, you should target both BRAF and MEK. MEK is right below BRAF in the pathway, as I showed you. And combination therapy in multiple clinical trials is better than monotherapy alone for metastatic melanoma. So we have 3 approved combinations in the United States: dabrafenib and trametinib, vemurafenib and cobimetinib, and most recently, encorafenib and binimetinib. All are very similar, some differences in toxicity and schedule, but BRAF plus MEK is better than BRAF alone. So in metastatic melanoma, if we use a therapy, we use a combination. In adjuvant therapy, also there is one clinical trial that showed combination of dabrafenib and trametinib. This is a trial called COMBI-AD, compared to placebo, is better than placebo for high-risk melanoma. This trial was presented at ESMO a few years ago, but updated very recently at ASCO 2020 this year. And you can see that there is a sustained benefit in the primary endpoint of relapse-free survival, 52% versus 36% at 5-year follow-up now. And distant metastasis-free survival was also positive. I'm not going to show you that data because there's not enough time. So the choice really between immunotherapy and targeted therapy is there for us for certain patients, right? It applies to only patients who have the BRAF mutation. If you don't have the BRAF mutation, you cannot use targeted therapy. If you have the BRAF mutation, you can use either immunotherapy or targeted therapy. So how do we choose? And this applies to both metastatic melanoma and to adjuvant therapy. So once again, we have a decision point. When we have a patient in the clinic with melanoma, we perform the BRAF mutation test. If it is negative, the patient is wild type, we use immunotherapy for that patient, whether metastatic or adjuvant. And if the patient is BRAF positive, we have a choice between giving immunotherapy or targeted therapy, and we have to make a decision. So how do we choose? Now, remember, we'll start with metastatic melanoma, and I'll show you the data for metastatic melanoma, but we extrapolate that to the adjuvant setting as well. And in metastatic melanoma, I think the most important thing to look at is, if you use immunotherapy, is there a difference if the patient is wild type or mutation positive? Because like in lung cancer, for example, when you have mutation positive disease, different targeted therapies for activating mutations, we use targeted therapy more than immunotherapy in those patients because it's not as effective. Not the case in melanoma. In melanoma, in fact, if you're BRAF mutant, the immunotherapy works as well, maybe even slightly better. So there is no reason to not use immunotherapy in a patient who is BRAF positive. What about looking at the data with the BRAF-MEK combination? I'm showing you dabrafenib and trametinib data. This has been analyzed multiple times, and I just want to show you an interesting finding that when you look at the baseline LDH of the patient, and we know that LDH is a bad prognostic marker for melanoma in the metastatic setting, patients who have a high LDH level above the upper limit of normal don't do as well with targeted therapy as patients with a normal or low LDH level. And that's important because when you look at immunotherapy, that does not seem to be the case. Of course, any patient with high LDH will do worse than normal LDH, no doubt. But with immunotherapy, it appears that patients with high LDH do quite well, not as well, but quite well. And we don't know if this is clear-cut or not, but many of us feel that for aggressive melanoma patients with high LDH, if you can use combination immunotherapy, Ipi/Nivo, we would choose that option over targeted therapy for this reason. However, I'll be very honest and say we don't know what the right answer is. And there are some ongoing clinical trials, randomized trials, which hopefully will answer the question, randomizing patients who have a BRAF mutation to receive immunotherapy or targeted therapy first, and crossing over at progression. So this is an intergroup trial from the United States. And then there is also a clinical trial from Paolo Ascerto called SECOMBIT, which he presented some very preliminary results at ESMO recently, but it's not mature data yet, looking at sequencing question, which goes first, which goes second, how do you combine things, and so on. So this is an ongoing work. So we don't have the answer right now. It is a clinical choice. What about potentially combining targeted therapy and immunotherapy? We know that both targeted therapy and immunotherapy work with patients with a BRAF mutation. What if you put them together? Make it a triple combination, a triplet. And I will tell you that the first time this was tried, it was with vemurafenib and ipilimumab, and it was not successful. There was a lot of toxicity, and it was abandoned. But since then, we have now better drugs. We have anti-PD-1. So when you combine anti-PD-1 monotherapy with combination BRAF-MEK therapy, you get some good results now. I'm showing you on this slide, multiple combinations. Dabrafenib, trametinib, and durvalumab, pembrolizumab, atezolizumab, lots of phase 1 and phase 2 trials done showing promising activity, which led to, of course, randomized clinical trials. So I want to show you 2 recent randomized clinical trials looking at triplet therapy for BRAF-positive melanoma. This is called IMspire 150. This is a trial looking at vemurafenib and dabrafenib plus atezolizumab or without atezolizumab. That is a design of the trial. It's triplet versus doublet. So 2 targeted therapies, Vem and cobimetinib, and atezolizumab is the experimental addition. So triplet versus doublet. And what did this show? This trial showed that progression-free survival was superior to atezo-cobi-Vem versus placebo-cobi-Vem. So showing that the triplet had a better progression-free survival. This was recently presented this year at AACR, virtual meeting. As you all know, every meeting this year is being virtual. And it showed that progression-free survival was superior. However, overall survival still immature. And the toxicity I'm not showing you, but it looked like it was a little bit higher, but not that bad. So this led to the FDA approving in the United States recently the triplet combination of vemurafenib, cobimetinib, and atezolizumab for BRAF-positive melanoma. So another choice. Maybe we don't need to sequence, maybe we don't need to choose, we can give all 3 together. That's a possibility. However, the data are still a little bit immature. And what was concerning is at the most recent ESMO meeting, there was another clinical trial looking at spartalizumab plus dabrafenib and trametinib. So dabrafenib and trametinib are BRAF-MEK combination therapy. Spartalizumab is another anti-PD-1. And this triplet was tried versus doublet therapy. You can see the trial design here. And unfortunately, this trial did not show a benefit of the triplet over doublet. It was a negative trial. So leading to some confusion here. One trial is positive, one is not. And therefore, I think we need more data. There is plenty of data coming out on triplet therapy, and we'll have to see. But I will mention that it is an option now for some patients. Of course, very expensive to combine all 3 drugs together. And toxicity is manageable, but it's a little bit different. You have to be a little bit more careful with the triplet combination. So I gave you a very quick summary of what is going on in the world of melanoma with targeted therapy and immunotherapy. And I would like to summarize by saying that immunotherapy with checkpoint inhibitors is a standard of care, not the standard of care, but certainly a standard of care for all suitable patients with melanoma. It doesn't matter, BRAF positive, BRAF wild type, doesn't matter. You can use either single agent anti-PD-1, and that would be for adjuvant therapy and metastatic disease. And if you choose combination therapy with anti-PD-1, CTLA-4, Ipi/Nivo, that is only for metastatic disease. In fact, I want to mention that I'm not going to show you the data because you don't have all the data, but in the adjuvant setting, by the way, there was a randomized trial combining Ipi/Nivo, comparing with Nivo alone, and did not show that it was better in the adjuvant setting. Very recently, just last week, there was a press release. So we have to look at that and see what's going on there. But in the adjuvant setting, if you use immunotherapy, it needs to be monotherapy with either nivolumab or pembrolizumab. For BRAF mutation positive patients, there is a choice between targeted therapy, combination targeted therapy, BRAF-MEK, versus immunotherapy, which could be monotherapy or combination. It is still a clinical choice, as I showed you. There are clinical trials going on to try to understand which we should do first, but we don't know the answer to that yet. Now, as I showed you also, we can now combine all three together. It is possible to do so. At least in one clinical trial, there was a benefit shown in progression-free survival. So the triplet is a newly approved combination in the United States. I'm actually not sure if it is even approved in Europe yet. I don't know, and I don't think it is approved in any country in Latin America, including Mexico, yet. So we have to see. And I think what is not going to go away anytime soon is the fact that we are clinicians and we have patients, and we have to make clinical choices based upon the data we have. It is still a clinical choice. Nothing, I think, in melanoma is black and white. It's not have to do this or you have to do that. There are choices. Sometimes it looks like this is better and you can choose that, but it is always going to be a discussion with the patient and depends upon what is available to you and your country and what is available to the patient in the health system. I think these are very important issues. So once again, Hector and colleagues, thank you for allowing me to participate virtually. And I hope once again to visit Mexico and come back for a live meeting when things change. And good luck and enjoy the conference. Thank you very much.
Muchísimas gracias al doctor Sanjeeva Garwala, que transmitió su video. Tenemos una sesión de preguntas. Agradecemos al doctor Egermont y al doctor Walsh que hayan permanecido con nosotros. Y realmente sus contribuciones creo que son muy importantes para un país en desarrollo como es nosotros. Doctor Egermont, tengo una pregunta para usted. Usted fue realmente uno de los que más experiencia tiene en el interferón pegilado. ¿Usted cree que actualmente en un país como México, donde tenemos una gran cantidad de pacientes y el interferón pegilado estuvo solamente para un grupo de pacientes que tenían ganglio centinela positivo y tenían un tumor primario ulcerado, cree que realmente todavía tenga un papel el interferón pegilado?
Okay, no, so the question is, the answer is very simple. No, interferon basically can be prescribed to patients with ulcerated primary melanomas that are stage 3 or stage 2B based on the data, on the meta-analysis, and confirmed by the pegylated interferon trial, but only in countries where the other drugs are not available. So this is still a massive amount of countries where the new drugs are not available for adjuvant use. And in those countries, for patients who have ulcerated primary melanoma that now presents itself in general as a stage 3 melanoma, then they can have interferon prescribed, but only if it's ulcerated melanoma biology. If it's non-ulcerated melanoma biology, forget about it because interferon has no effect.
And Dr. Egermont made that key observation that ulceration of the primary melanoma is actually a predictor of improved survival rate. That is a sensitivity to interferon, whether it's alpha interferon or pegylated interferon.
Yeah.
And conversely, there's zero survival benefit of any form of interferon in non-ulcerated melanomas with stage 3 disease or 2B.
Exactly. The meta-analysis has 8,000 patients of 14 adjuvant interferon trials randomized against placebo. And there is no benefit at all, 0% in non-ulcerated melanoma patients, which was 70% of the patient population of those 8,000 patients. And all the benefit was only limited to patients who started with an ulcerated primary melanoma.
May I put in a pitch for Cancer Expert Now to those of you who are listening? We have a collaboration with SMeO, and those of you who are listening, whether they're surgeons, medical oncologists, could register, and we can get the URL later, and apply the real-world application of resources available in your practice so that experts such as Dr. Egermont, myself, Dr. Agarwala, and others around the world could respond on our smartphone on a text-based system to respond to your practical questions in your practice with real-world experience based upon resources available in your local area. So that's cancerexpertnow.com, and Dr. Saeed could probably post this on the SMeO website so that you could take advantage of this educational service, which is done at no cost. It's paid for by a CME grant by Merck Sharp and Dohme Pharmaceutical Company.
Muchas gracias por esa invitación, doctor Shalbach. Hay una pregunta de nuestro auditorio para usted. La pregunta es, en el escenario de los estudios presentados MSLT2 y the COG Trial, ¿qué pacientes con un ganglio centinela positivo, la sola disección del ganglio centinela es terapéutica, y en qué pacientes se debería de completar la disección linfática?
So this comes down to, in my practice, a individual decision with each patient, and it's whether the benefits outweigh the risk. So in the first place, if a completion node dissection would delay adjuvant systemic therapy, if there was a risk, especially of lymphedema or wound complications in patients who are at increased risk, then I would have some reservations. The second is the indications. Clearly, patients with low tumor burden in their sentinel node have no risk of additional node metastasis, do not need a completion node dissection for staging. But as the tumor burden increases, let's say to 8 to 10 millimeters, that risk may approach 30 or 40%, and it may be necessary to do this for regional disease control and for staging the patient. However, if the patient and you as the physician decides not to do that, then the next approach is to follow them regularly for the next 5 years with ultrasound guidance, and then determine whether or not they need a completion node dissection for recurrence later on. My experience has been in those patients who get lost to follow-up then may present with bulky disease that may not be operable or may have multiple disease that requires a more radical surgery and radiation therapy. So I think we have to individualize this and select our patients according to whether the benefits outweigh the risk. Dr. Egermont, what do you think?
I live in a country that's densely populated, where you cannot live further than 45 minutes away from one of the university medical centers. This means that we do not necessarily have this problem of follow-up. Follow-up in the Netherlands is very easy because you always practically live next door to a hospital. This provides the luxury to say that we have stopped doing completion lymph node dissections and we follow up all patients with ultrasound. So we start adjuvant immunotherapy in general with anti-PD-1 uniformly in stage 3 patients, and we follow them up with ultrasound every 3 months. And so this distance problem, which you do have in Texas, and this distance problem that you do have in quite a few states in the heartland of the United States, where you have to travel half a day to get to your hospital. We don't have that, and therefore we simply have stopped doing completion lymph node dissections, follow everybody with ultrasound every 3 months, and we start immediately adjuvant, usually anti-PD-1 therapy after the positive sentinel node outcome. There is only a real discussion if the tumor load in the if there's only one sentinel node. If it's smaller than 1 millimeter, then we look and discuss with the patient in terms of age. and in terms of whether they have autoimmune disease and what is their prior history, whether this is a good choice where the risks do not outweigh the potential benefits. But if age or autoimmune history are not the impediments, then usually we start adjuvant therapy and we follow up with ultrasound.
And my only point is, if somebody lives in Houston, that's easy.
Yeah.
But if they live in West Texas and those listed in some places in Mexico, they may not have patients who are reliable for follow-up, or they may not have ultrasound ability. And in those circumstances, I think we have to individualize that based upon the local resources.
I fully agree, Charles, with you. In those patients, I would say, let's get it over with and maximize the safety scenario that we're done now. And then we have chosen the pathway for optimal regional control, because in that case, it could derail into a problem. So I think we're actually on the same line, but we practice under different circumstances.
Exactly. So we're saying to you in the audience, if your patients don't have access to all the adjuvant therapy that we do in MD Anderson or in Germany and the Netherlands, then you may have to use a more surgically based treatment and hope that the healthcare delivery system in your area then allows for the payment of these more expensive adjuvant therapy and they become more widely available. Next question.
Bueno, creo que se ha terminado el tiempo. Les agradecemos sus valiosas aportaciones. Estamos muy agradecidos con ustedes, doctor Charles Barch, doctor Egermont. Les mandamos un cordial abrazo. Les dejamos las puertas abiertas para cuando quieran venir con nosotros. Muchísimas gracias.